Okay.
Please, yeah.
Hand over the session to Dr. I think Dr. Deepak. Yeah.
No, to myself first. I'll do the
Sorry, Dr. Arun.
yeah,
I'm sorry.
endocrine one first, and then
Endocrine and cardio.
yes, that's
Yeah, fine.
so we'll have the discussion in the end. Is that okay?
Yes. We'll have a discussion in the end only. Fine.
Perfect. Yeah.
Dr. Shavik, we are good to go. You can start.
I will start, Vinay?
Yes, doctor.
Yeah. Good evening and welcome to the expert crosstalk on Empagliflozin, multi-pronged, multifaceted and multi-benefits. As we already knew that ESC 2020 was memorable with a path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, that is cardiology and endocrinology, which will bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to Emperor-HF trial, does SGLT2 inhibitor may be considered as an important drug for heart failure? To get the answer, let me introduce today's speakers. Today's speakers are Dr. Arun Menon and Dr. Deepak Davidson, and I'm your moderator, Dr. Shavik. Dr. Arun Menon is a HOD and senior consultant endocrinologist at Lisi Hospital at Kochi, and formerly is a professor Department of Endocrinology at Abhidhan Institute of Medical Science in Kochi, and also a consultant endocrinology at Darlington Hospital, UK. And he has got several other additional degrees like CCT and FRCP, and his area of interest are osteoporosis, thyroid disorders, diabetic retinopathy, and nephropathy. And also he was also Secretary of Indian Thyroid Society and Kerala Endocrine Society 2012-2016. I welcome Dr. Arun Menon in this expert web talk.
Thank you.
Yeah, welcome, sir. And our next speaker is Dr. Deepak Davidson. Dr. Deepak is the Chief Intervention Cardiologist at Caritas Hospital in Kottayam, Kerala. And he is also a speaker, faculty, and course co-director in various national and international conferences, and also is famous in conducting workshops and trainings on complex coronary angioplastics and imaging. I welcome Dr. Deepak in this expert web talk. And I'm handing over the session to Dr. Arun to start with the presentation.
Good evening, everyone. Thanks, Dr. Shavik, for the kind introduction. This evening, over the next hour or so, or probably in the next 45 minutes, we will discuss the various aspects of empagliflozin. As you all know, this drug or this molecule and this group of drugs, which is the SGLT2 inhibitors, have really hit the news in a big way over the last, say, 3 or 4 years. Largely because of the wonderful results that we have had from the RCTs on various aspects. And many of these, to be honest, were initially not thought of that we would get such good results in many complications in diabetes. Although initially it was touted as just a anti-diabetic drug and which would actually improve the glycemic control very much, its benefits in other systems have come as a pleasant surprise. When I say that, mainly in the heart and the kidneys. So today, my job is just to set the stage in terms of the glycemic efficacy, the glycemic action, look at some of the studies that I'm not going to go into all the previous data. You would have all heard hundreds of times about empagliflozin and its studies, but some of the salient features of that drug, and then look at some of the newer data. So that will be my job. And then the exciting bit actually would be done by Dr. Deepak because the real interest is in its in the SGLT2 inhibitors, especially empagliflozin and also dapagliflozin more recently, its effect on cardiac function, on the studies like DAPHF and so many other studies along those lines. So its action on left ventricular function or benefits on left function is of great interest. I'm sure we'll see more and more studies on all these molecules over time. So with that introduction, let me go into my kind of slides. So if you look at the SGLT2 as a group, the three that have they hit the market very early on. First was dapagliflozin, then canagliflozin, and empagliflozin. I'm talking about the Indian market, and these three have been around for nearly 10 years. So really, okay, I'm probably just less than 10 years, but these drugs have been around for some time now, and we all have quite a lot of experience with using these drugs. And the number of publications that have come out, and all showing fairly consistent results. Consistent results we will discuss what they are, but the initial interest was all on its glycemic efficacy, its effect on weight, its effect on blood pressure, and that's where it's so all the kind of metabolic parameters of diabetes was where the initial research and studies were going on. And then when the cardiac safety trial came out, it was clear that empagliflozin reduced mortality and reduced MACE and many aspects of MACE. And then later on, the studies showed that there was a reduction in heart failure, which was significant and consistent. So this is where we have reached now. Add to that group is remogliflozin, which has been around for some time, but in India, probably the latest entrant this last couple of years, which also seems to have emerging evidence around it. So the action is something which you all know. I'm talking about the SGLT2 inhibitors action. So we know that more than 180 grams of glucose is filtered by the glomeruli every day. Once that comes into your proximal convoluted tubule, PCTs, what happens is that the SGLT, there are two sets of receptors, which is SGLT1 and SGLT2. The SGLT2 predominantly is in the kidneys, SGLT1 being in the GI tract. The SGLT2 will aid the absorption of this glucose back into the bloodstream. So that is the action of SGLT2 receptors. Now, as you know, what happens with SGLT2 receptors is in type 2 diabetes, there is an upregulation of these receptors. SGLT2 receptors are now overly expressed or upregulated, because of which there is an increased absorption of glucose back into the blood so when your sugars are high, there's more that is going into more load that goes into the glomerulus and into the PCT, but more is absorbed as well. So this has been one of the pathologies of the sugars remaining high despite many other modes of action. And this is where a SGLT2 inhibitor, which predominantly inhibits those receptors, came in. And by inhibiting that receptor, you are aiding excretion of the glucose and the osmotic kind of diuresis. So that's what happens with this drug. So this is in a very, very simplistic way. Now, what about the pharmacological properties of the available SGLT2 inhibitors? The three that I have put here are worth discussing and spending a few minutes on. Again, all of you have used quite a bit, and many of you will know this very well, but it's still important for us to just remind ourselves of what the doses are, which will help us. Obviously, we are going to use these molecules more and more as time goes on. So the empagliflozin came in 10 milligram and 25 milligram starting doses. And those are the doses that are being used in all the countries. They are administered once a day. In fact, all of them are administered once a day. The doses of DAPA again is 5 and 10. Cana is 100 and 300. So this is what the doses are. Now the peak plasma concentration, by and large, all of them gives you that level, post-dose level by the peak level by about 2 hours. The absorption, again, you can see that the oral bioavailability is fairly good for all of them, especially for DAPA, and the EMPA and CANA are comparable. There's no active metabolite. I think that's probably one of the things that we should note, because that helps. Many times that is one of the concerns, is it a metabolite that comes in from the drug which will cause other side effects. So that's necessarily not there. The elimination, again, there is some slight differences, if you look at it, this is mainly renally eliminated, EMPA as well as DAPA, whereas the CANA is more hepatic elimination. Although clinically, these effects don't necessarily cause any problems when you're using it in renal impairment patients. Previously, when we used to use it in renal impairment, but now obviously because of, again, we'll discuss those data perhaps at least briefly. We have to use, we do use them even in a reduced EGFR scenario. The selectivity of SGLT1, which is also another aspect. If you look at it, the EMPA and DAPA are more selective for SGLT2, whereas the CANA has got both actions, perhaps the SGLT2 and SGLT1 action. And there is, as you know, there is a sotagliflozin, which might hopefully come out in the next couple of years, which has got both, has got dual action. And what about the glucose excretion with higher doses? Again, comparable, perhaps CANA in the higher dose has got the most excretion. Although saying that, clinically, when you use these drugs, you don't necessarily see a huge difference in terms of HbA1c or fasting or ppbs reductions. All of them compares very well. I think that's one of the things with clinical experience that we have found. I don't think we can say that one is much more powerful than the other. The 300 of CANA perhaps is probably the real, which probably is slightly more powerful. But again, clinical studies haven't really shown much of a difference between these three agents. Now, what about the dose comparisons? So EMPA, EMPA 10 milligram versus empagliflozin 25 milligram. And let us look at the dose differences and the effect on each of those parameters for diabetes. So here, what I have projected, the data is on the HbA1c data. Okay, so from baseline, what is the reduction in HbA1c? So if you look at this blue is 10 milligram, the red is 25 milligram. So you can see here, so you can get a fairly decent reduction in HbA1c with both doses. So many times when you're using it as a combination along with other drugs or with other, I'm talking about oral anti-diabetic drugs, OADs or insulin, you may not necessarily need the bigger dose. You might easily get away with a smaller dose. This is the same across the board, whether using it as monotherapy with metformin, with pioglitazone, with sulfonylureas, with insulin, so you name it. You use it with any agents. Both doses are comparable. Of course, there is definitely some benefit to be obtained by going for a 25 milligram, but you could easily start with 10 milligram, see whether you're getting the desired effect. But keep in mind that by increasing from 10 to 25, the benefit you're going to get is not huge, although there might be some benefit. And so you have to customize that for your patients and look at your patients and see whether you would benefit largely from that increased dose. And if you feel, then of course you can, that's good to hear. So this is about HbA1c. What about the body weight? Again, you can see the difference is not huge, whether you use 10 or 25. Definitely there is an improvement, slight improvement that you can obtain. So in those sort of scenarios, you might want to use the smaller dose first, and then fully understanding that increasing the dose you may not get the double the effect. You might get some marginally increased effect. You might go for that. Interestingly, in mild renal impairment, you will get a better effect with 25. Now, this is not surprising, isn't it? Because it acts through the kidneys. So once you have some renal impairment, the effect would be blunted of the 10 milligram dose. So hopefully you're getting a better response to 25 milligrams. So again, that is not a surprise, but just a point to note. What about the blood pressure? Because this has been one of the interesting areas and aspects, and people have discussed at length, and there have been so many theories of why the blood pressure comes down and whether these are clinically useful and all that. And again, I would like to hear Dr. Deepak's comments in the end about what he feels would be the reason for this sort of reduction and whether that is clinically meaningful. So again, if you look at it, the doses are fairly comparable. Again, in mild renal impairment, you might get much more of a benefit, but you can see that by and large, it's not a huge this thing, whether you use it as a monotherapy with metformin with pio or with metformin plus sulfonylurea. So you get good good reductions with both, slightly more reduction with the 25 milligram. Now, keep in mind that these are all some of these are statistically significant, and statistics does so that does give you this thing that in the right patients you should use a bigger dose. I'm not saying that you just stick to 10 milligram and just leave it like that. So don't get me wrong there. What I'm trying to say is you start with a starting dose, you get good benefit, you then decide depending on all these parameters whether you want to increase to 25. But by and large, most people will get good response even with the smaller dose. You can then decide whether to increase it or not. That's what was meant. Now, some of the more data that we don't necessarily discuss all the time, but it's interesting, is to look at the 12-week ambulatory blood pressure monitoring studies with empagliflozin in patients with type 2 and hypertension, and hourly mean systolic blood pressure. And what you see here is that the reduction BP were not associated with increase in pulse rate, but you take it, this is placebo. So the placebo, you get a slightly lower blood pressures with empagliflozin and with 10 as well as 25. So it is, you maintain the kind of same, same blood pressure profile. So you're not changing the profile in very much. So the BP is not artificially lowered at any time. So in a way, the chance of forceful hypotension is less. Of course, if you're using it with other antihypertensives, it is different. I will not go into that discussion, but clearly when you're using it in somebody who has got so many other cardiac drugs plus other antihypertensives, you have to be careful. You have to look at all those medications, perhaps if required, discuss with a cardiologist also as to which one can be reduced. So all those things would usually come into clinical practice, but at least it's good to see that the blood pressure is not kind of artificially lowered. It just keeps that pattern that you would expect. And again, if you look at the diastolic, pretty much the same kind of picture, whether it's placebo or 10 or 25. So, and there is no reflex tachycardia. So that is that. And then if you look at the SGLT2 on glucose control, body weight, and systolic blood pressure, as we said earlier, this is what the studies have shown. So you can see that as monotherapy, we have said this already, but what you expect in terms of HbA1c reduction with most of them, at least in studies, is a HbA1c reduction of 0.6 to about maximum 1. That is what studies show. Interesting, because there are so many of our patients who respond much better than this and who get, but clearly there will always be patients who don't necessarily respond as well. So some of the patients really benefit from in HbA1c reduction. I'm talking about HbA1c reduction. So it's worth using this drug in a combination with other medications, including insulin. The effect is also there on the fasting plasma glucose, as well as on the body weight and on the systolic blood pressure. So I think it is important. And typically the weight loss that you see is about 2 to 3 kilos. That is what you would expect in most patients. There are still some patients who will lose much more than that. So this is again it's a beneficial effect that you obtain with this group of agents. Now, what about the safety and tolerability? Another important aspect that when we are using newer drugs, as well as when we're using drugs in combination with other drugs, that we need to be aware of. And if you look at the summary of adverse events, you can see here the comparison of placebo with 10 milligram, with 25 milligram. And what you're seeing is they're largely comparable. This is not a huge difference in terms of. So what we're saying is it's not much more than a placebo. The side effects. Not to say that there are no side effects with this. I'm not trying to say that, but the serious side effects are hugely. I mean, perhaps with 25 there's a little bit more, but again it's comparable because if you look at proportionally, it's 13.4 versus 10.3 versus 12. So they're all kind of comparable. That's what is shown in this graph as well. So not a huge increase in side effects perhaps very comparable to placebo. Saying that there are specific side effects like the thrush, gentle thrush, vaginal thrush in females, the penile thrush that you see in males, increased urinary tract infections in people who are prone for UTI. Not in everybody, but in prone for UTI. So you have to be careful with that that side of things. And all the other things have really not been a big problem. It's just this this lower urinary tract infection in some people, but more the thrush that is probably the biggest kind of side effect that you would see, and that usually doesn't become a problem. That doesn't become a problem. Sorry, I think my slide has gone off. Yeah, so that's fine. Now, if you look at one of the most important studies with empagliflozin and the cardiovascular outcome. So this was the EMPA-REG study, and this was looking at the empagliflozin and cardiovascular outcomes in patients with type 2 diabetes at high cardiovascular risk. You know that this was a study that was done in a high cardiovascular risk group. As you know, 99% of patients either had a cardiac event already, people who are enrolled into the study we are talking about, okay? So 99% of patients either had a cardiac event or were at very high risk for a cardiovascular event. So this is a very high risk group that was studied with this empagliflozin in this study. So this was a cardiac safety trial. And you know, I'm not going to go into the cardiac outcomes. I'm sure Deepak will be discussing that. If you look at the renal outcome of it, okay, so there were many parameters to look at, but this is a renal outcome. The important bit, of course, is a cardiac bit, but we'll discuss that later. So the renal outcome, you can see that there was a significant improvement in terms of nephropathy. So although there is an initial drop in EGFR, which you always see with these drugs, but that is not to say that your renal function worsens, because the rate of fall of EGFR from then on is actually much slower than with any other drugs or with placebo. So clearly there is a benefit to be had by using these agents, even in renal impairment patient, but the worsening or incident nephropathy is less. The progression to macroalbuminuria is less. We are talking about people from microalbuminuria to macroalbuminuria. That is less in people who use empagliflozin. And if you look at the composite renal endpoint, which would include people ending up with end-stage renal disease or doubling of creatinine, these are the kind of parameters that you look at, people ending on dialysis and that sort of thing, that is also significantly less. And you can see the hazard ratios here. See, it's 0.61, 0.62, 0.54. So remarkable improvement in kidneys, which was actually not expected, to be honest, when these drugs were initially launched in the market. So that sense, from a concern that EGFR might go down and it might affect the renal, affect the creatinine or the renal function, the concern that it might cause sodium or potassium or dyselectrolemia or electrolyte imbalances, it has come to a stage where we now use it predominantly for the renal reason itself, because they will benefit patients who already have some renal impairment and who have proteinuria and that sort of group. So that's been a marked change from of our understanding over the last few years. Now, in patients with type 2 diabetes and high risk, high severe risk, which is what we said in the EMPA-REG, empagliflozin given in addition to standard care, reduced heart failure, hospitalization, CV death. So those were the two main outcomes of that. So the heart failure hospitalization, HHF, the hospitalization for heart failure was reduced in pretty much all studies, any study you look at with SGLT2 inhibitors, but EMPA powerfully showed that as a first, in the initial study itself, as well as cardiovascular mortality. And I think that's been, in fact, the only drug that has shown a reduction in CV mortality. Of course, it might be because it studied a kind of patient group who already had very high cardiovascular risk. So it was easy to demonstrate a reduction in cardiovascular death with those agents, whereas others were probably, the studies were done in a less high risk group. So those were, so the reduction hospital for heart failure and CV death has been the standout results of empagliflozin in this study. And there is consistent benefit observed both though with or without heart failure at baseline. I think that's another important point to note. So you don't have to wait for heart failure to set in. Again, I'm sure Deepak will talk about this thing. Heart failure is notoriously difficult to diagnose, and I don't know whether our clinical diagnosis over the years of saying, okay, this patient has heart failure and this patient hasn't, has been a very clever way of doing it. Although clinical medicine is always the gold standard, and we want to use that in all this thing. We know the limitations of clinical medicine. We have to understand that. And when we know that we have a high-risk patient group, i.e., the diabetes patients with high cardiovascular risk, you have to take on board that the heart failure, especially maybe asymptomatic heart failure, is there in a huge group. Now, what the study is even showing is that whether you have shown heart failure or not at baseline, you would still get consistent benefit in reduction of heart failure moving forward. So somebody who has not got heart failure, his chance of having a heart failure is less. Somebody who has already had a heart failure, his chance of having further episodes is less, or hospitalization is less, and CV mortality is also less. So excellent results. Now, what are the newer results before I conclude? What are the newer sort of data that we need to look at? One is, this is something which came in 2020 June. So this is in ADA 2020. This American Diabetes Association meeting in 2020. And what they looked at was a post hoc analysis of EMPA-REG outcome. So there's the same study, the old study, but they were looking at some of the post hoc analysis of this. And what they looked at there was how early after treatment initiation are the CV benefits of empagliflozin apparent. So we know there is a benefit, but how quickly does this benefit come? And does it come in 2 weeks? Does it come in 2 months? Does it come in 2 years? I think it's important, isn't it? Because we know with statins, for example, the benefits and the time kind of this thing, how long you have to take statins and all that. So like that, it is important with a drug to know how quickly you're going to get the benefit. And I think that gives you, the added confidence of using it, early on. You want to use it early so that you pass on the benefit. So in the EMPA-REG outcome trial, what it showed that the CV benefits with an early separation of cumulative incidence curve. So there was an early separation. This is very, very clear from the beginning itself, because the cardiovascular benefits seem to be coming very, very early on. So it doesn't take months or not even weeks. Actually, it's within a couple of weeks that you start to see the effect. And I'll show the figures, show the graph in a moment. What was explored here was at what time point after randomization the benefits became apparent, and that was looked at in this study. The hazards ratio, they stabilized as number of patients with events increased over time. So that means the benefit continued in this group of patients. The benefits of empagliflozin in reducing risk of heart failure, CV death and heart failure and CV death emerged within weeks after treatment initiation. And that is what is shown in this picture. So what is shown here is that by day 17, you are starting the earliest effect on hospitalization for heart failure seems to be evident or apparent from day 17. So what we are saying here is that if you use this drug early on in somebody who has had an admission for a cardiac event and you started this medicine, the chance of having a repeat heart failure or admission with heart failure, that reductions, you can show a reduction in, if you look at a big group, by day 17, you can start to gain the benefits of this. That means 17 days you have used, you're starting to see the benefit. So that is very quick for a drug to have its long-term benefits proven. So I think it's a remarkable result in this setting. And then what about the time to benefit for heart failure or CV death? If you look at it, it's again day 27. So within a month, you can see that a month of using this drug, you have already reduced the risk of death in a group of people. Of course, one person, it's difficult to say that way, isn't it? But it's statistics. And what you're saying is you can reduce the death by using even for 1 month. And of course, you continue to use it. You can see here that the benefit continues to accumulate. So these are excellent results in the sense that the benefit comes on very early on, whether that is for hospitalized for heart failure or whether that be for cardiovascular death. So that is one of the newer data. Now, what about this one? This is the effectiveness and safety of empagliflozin in routine clinic care patients. These are interim results from Emprise study. Okay, so there's another study which was looking at, this is a real kind of a real life, real world data, as they call it, something like that. So basically here what you're looking at is, they're looking at the empagliflozin versus DPP4 inhibitors, because that's the other group of drugs that have been used. And what they've looked at is 39,000 matched pairs. And what you see here is very, very impressive, and something which we, so you're comparing a SGLT2 with DPP4, because we have all got significant, quite a lot of confidence over the last decade or 15 years of using DPP4 inhibitors, and we are very confident of using it. But is there an added benefit by using this? Of course, there is. Studies have shown it, and if you can take this as a direct comparison, then it says there is benefit in direct comparison as well. So what is shown here is that early findings from Emprise, the empagliflozin is associated with a decreased risk of hospital heart failure and a similar risk of MI and stroke in routine clinical. So the benefit is really in reduction of heart failure. And of course, we have shown that the mortality reduction is there. But of course, in this sort of this thing, it is difficult to look at, because this is a real world data, and it's difficult to make out the difference. Again, this was again shown in, this was an abstract in ADA. In a subset of population, in a subset of population with complete mortality information. So in everybody, this mortality information was not there, but in the subset that it was there, again, it shows that it decreased all-cause mortality. So you can see here again the hazard ratios. See, it's not crossing. It's 0.58 is the top end, 0.3 to 0.58. So 0.42, that is significant in terms of hospitalization for heart failure. Even the all-cause mortality is showing. Of course, MI and stroke, it didn't show any difference. So that was neutral because it crossed the line of 1. So, so clearly, again, telling us that these results that we are seeing with hospitalization for heart failure and all-cause mortality are real, consistent, and something which we can start to accept with confidence. So, how are the studies progressing? The CV safety trials are being conducted for each compound within the newer class, as you all know. And from 2013, there has been a series of trials, and it's almost now difficult to keep pace with all these trials, because the cardiovascular safety trials had become, you know, the FDA had insisted that all these drugs should show cardiovascular safety. This is obviously, as you all know, was after the saga of rosiglitazone and the glitazones, and obviously they had made it compulsory that we show a cardiovascular benefit, or at least cardiovascular neutrality. And of all
Vinay, give us a cue.
Yes, doctor.
Yeah.
Yeah, once the streaming starts live, please let me know.
Yes, definitely, Dr. Deepak.
I am ready.
Yeah.
I hope you are seeing my slides also, right?
Yes. It's visible and you are audible also.
Yeah.
No issues. Yeah.
Okay, doctor, you can start. We are live now.
Okay, we are live. Okay. Thank you so much, Team Lupin. I thank Dr. Shovik for the Nice introduction. Let me also thank
Thank
Dr.
you, sir.
Arun. It was a wonderful, very, very simplified way of speaking, and it was very informative. Now we had a small technical glitch, and hopefully, I think we have another 20 minutes for the streaming to continue. So I think I'll rush through a few slides and try to finish off within another 15 minutes or so that we can have at least 5 minutes for discussion. Well, this slide we've already seen. We know that whatever sugar it reaches the glomerulus, it's been filtered through the glomerulus, and 90% of it is being reabsorbed from the proximal convoluted tubule with the help of SGLT2 enzymes. And once we start our patients on SGLT2 inhibitors, what happens is it inhibits the reabsorption from the proximal convoluted tubule, so that you have more of excretion of sugar through the urine, and you have a bit of osmotic diuresis, and you have less of calorie inside the body. So we have so many molecules available as of now, the DAPA, Remo, Cana, and presently today we are going to discuss something on empagliflozin, whatever data that we have since probably 2015 down the line. Now, I'll start with the case history of a 69-year-old female with a 69-year-old male who presents with class 2 dyspnea on exertion. He's been a diabetic for the last 30 years on insulin, sulfonylurea, and metformin. He's on aspirin 75 milligram per day. He's been a hypertensive on ACE inhibitor. He's got dyslipidemia on statin. His BMI is a bit on the higher side. He also has coronary artery disease. He has evidence of old infuval myocardial infarction on ECG, and his ejection fraction is around 40%. He's got mild left ventricular dysfunction. Now, what about the long-term outcome of this particular patient? He's been a diabetic for a very long time. We know that this particular patient, from the Framingham study, when you have somebody who's got a long-standing diabetes, he's more prone for developing MACE, that's he's more prone for developing myocardial infarction, he's more prone for developing strokes, peripheral arterial disease, and he's also prone for developing cardiac failure. And we know from this particular Framingham data that heart failure is the most commonest event that can happen in a diabetic patient. Well, now you would always want to prevent these sort of MACE from happening for our patients. Now, how could we do that? We know that our patient is a diabetic hypertensive dyslipidemia. We would always want to control the diabetes well. We would want to control hypertension as well as dyslipidemia. Even if he's not a dyslipidemia, we know that statins would definitely help them out. So when he has multiple risk factors, diabetes for almost 30 years, he would definitely be benefited from a bit of antiplatelet agents also. Now, what is the role of SGLT2 inhibitors? Now, for the last 5 years, we know that SGLT2 inhibitors also would try to bring down the MACE in patients who have diabetes, who are prone for developing cardiovascular events. Now, when you look at the control of diabetes, less intense versus very intense diabetic control, we know that almost all the trials mentions that we need to have a good glycemic control so that the future MACE could be significantly reduced, probably except for the ACCORD and ADVANCE trials, wherein patients had diabetes for a very long time. They had more of hypoglycemia. Because of that, the events were more in that subset of groups. So, but at this point of time, we know that when you have a good intense control of diabetic status, we are likely to have less of MACE in future. Now, similarly, that's what most of the trials say. Now, in this particular slide, you could understand here that the heart failure outcomes are significantly better with empagliflozin. We know that these are the right from UKPDS. There are so many trials looking at the MACE as well as looking at the MACE in patients who are diabetic. Now, these are the trials looking at that. Now, at the extreme end, you could see here that even the heart failure risk could be significantly reduced when you use SGLT2 inhibitors for managing our patients with diabetes. This was a trial that was published in 2015 in NEJM, the Empire trial that's been alluded by Dr. Arun too. Now, this particular subset of patients, they are extremely high-risk subset of patients, almost 100%, 99% of patients, they had established cardiovascular illness, and almost 10% of patients, they had history of heart failure in the past. And the subset was a high-risk subset. The eGFR was above 30% in all these patients, and they were followed up for a while. Now, what is the primary outcome? What were the primary outcomes that were looked into? What were the secondary outcomes? Now, regarding the primary outcomes, they looked at the MACE in this subset of patients. In the secondary outcomes, there were multiple things that were evaluated, including the renal function, including the admissions, recurrent admissions for heart failure, hospitalization. All these things were looked into. And when they followed up the patients for around 24 months and beyond that, they made out that with empagliflozin compared to the routine treatment for diabetic patients, you have significant reduction in MACE. That's what the slide makes us understand. If you look at the cardiovascular death also was significantly reduced in the empagliflozin group. The all-cause mortality also was significantly reduced, and surprisingly, the hospitalization for heart failure was significantly reduced. We know that only 10% of patients has had previous episodes of heart failure in these subset of patients, and as you go through the trial, when they were followed up for so many months, we made out that the hospitalizations for heart failure also were significantly reduced. Now, when you look at the secondary endpoints, the MACE was significantly less, except for non-fatal stroke. All other parameters were in favor of empagliflozin. And as alluded by Dr. Arun, we also know that the renal performance also over a period of time was much better in the EMPA group compared to the conventional treatment group. So the worsening of nephropathy, progression to albuminuria, the composite renal outcome, everything was better in the EMPA group compared to the placebo group. So we come to know that in patients with or without heart failure, in diabetic subset of patients with high risk, somebody who's had an event, cardiovascular event in the past, in these subset of patients, when they are treated with empagliflozin, they tend to have a better outcome. And as Dr. Arun has already mentioned, in post hoc analysis, we made out that these benefits occurred very early during the treatment course, as early as weeks, probably a couple of weeks. If you look at the heart failure outcomes, hospitalization for heart failure outcomes, the benefit was seen as early as 17 days. And when you look at the combined hospitalization for heart failure and cardiovascular death, the benefits were seen as early as 27 days. So there are a lot of postulates and mechanisms that's been implicated why SGLT2 inhibitors could reduce heart failure. These are a few of them. You tend to have a reduced preload and afterload. So you tend to have reduced wall stress. You tend to have LV dimensions becoming smaller and smaller over a period of time. You have reduced intravascular fluid status. You have reduction in interstitial edema. That is something more important when you treat your patients with diuretics and when you treat your patients with SGLT2 inhibitor. We know that diuretics would bring down the intravascular volume and SGLT2 inhibitors would reduce the interstitial edema. So moreover, you tend to have a bit of natriuresis. You have an improvement in renal function. We know that in patients with cardiac with long-standing diabetes, they tend to have renal involvement. So as you treat them with more and more of medication, the renal function tends to deteriorate. So these all can lead on to further worsening of cardiac issues, or the MACE could increase. Now, hospitalization could be significantly reduced because the cardiorenal syndrome also is taken care of with the help of this particular molecule. So if we look at the various trials addressing this particular issues with SGLT2 inhibitors, we have the EMPIRIC study with the empagliflozin, the CANVAS with canagliflozin, and the DECLARE-TIMI 58 with dapagliflozin. You could see here that consistently, that the hospitalizations for heart failure was significantly reduced with all these molecules, and the renal function also was the renal function also improved in these subset of patients who were treated with SGLT2 inhibitors. Now, so we know that the MACE could be prevented significantly with the help of SGLT2 inhibitors. Now, what about the treatment of heart failure? We know that there are patients who have heart failure. They need to be treated with beta blockers, AC inhibitors, ARNI, and MRAs. Aldactone should always be there in the list for treatment of these particular patients. Now, do we have something more important? Do we have a benefit with SGLT2 inhibitor as far as patients with heart failure are concerned? Now, till now, we've been discussing this particular molecule as a diabetic molecule, looking at the diabetic trial. Now, Now we shall go through a couple of trials wherein this particular molecule is considered just as a heart failure molecule. It's not considered as a anti-diabetic molecule, not considered as an oral hypoglycemic agent. It's just considered as a heart failure drug in this heart failure study. Now we know we at this point of time we have two major trials: the DAPA-HF trial looking at the usefulness of dapagliflozin in heart failure patients, and the Emperor trial looking at patients with heart failure with reduced ejection fraction. Now we know that both the trials came out with almost similar results, and when we go through this particular Emperor reduced trial, in this particular trial, this particular molecule was considered not as a oral hypoglycemic agent. It was just as a molecule which is used for treatment of heart failure. It's primarily irrespective of the diabetic status. In this particular trial, we know that only around 50% of patients were diabetic and rest 50% were non-diabetic. And these were the endpoints that we looked into. The primary endpoint was composite of cardiovascular death as well as heart failure hospitalization. The first secondary endpoint was heart failure hospitalization, and finally they also had a look at the renal involvement. Now in this particular trial study, all the patients had heart failure. They were on treatment for heart failure, and around 3,700 patients were enrolled, and they were followed up for around 1.5 years. And all the patients had ejection fraction of less than 40%, and they also had elevated NT-proBNP and EGFR. If you look at the EGFR, around 50% of patients had less than 60 EGFR. Now it's also worth mentioning that these patients were all very well treated. Almost 95% of patients were on beta blockers, spironolactone in around 70% of patients, AC and empagliflozin inhibitors in almost 90% of patients. So primarily these patients were treated very aggressively. In addition to that, they were started on SGLT2 inhibitor, and the results were very surprising. And you could see here that the primary endpoint of heart failure hospitalization and cardiovascular death was reduced by 25%. The secondary endpoints, the recurrent hospitalizations, was reduced by 30%, and even the renal events were significantly reduced by almost 50%. Well, the time to cardiovascular death and hospitalization, this is the same bit of information put in a different way. Empagliflozin significantly reduced the time to cardiovascular death and hospitalization in patients with heart failure. And you could see again here that the cardiovascular death, the hospitalization, and the composite renal endpoints were also significantly less. Now, when you look at the secondary outcomes, there were no significant episodes of hypoglycemia in this particular study. We know that 50% of patients, they were not diabetics, in spite of being non-diabetic. Treating them with this particular molecule did not lead on to significant amount of hypoglycemia. Now, so we know that this is an efficient molecule. It reduces the admissions for hospitalization. It could reduce the cardiovascular death. Renal function could be significantly improved. Now, what about safety of this particular molecule? Efficacy is good. What about safety of this particular molecule? The cardiovascular safety is good. The worsening of renal function, we heard from this trial that there is no significant worsening of renal function. Volume depletion was not significantly different compared to placebo. Hypotension was not significantly present. Symptomatic hypotension was not present. Hypoglycemia was comparable. Ketosis was comparable, even though in the DAPA-HF trial we had little bit of increased ketosis in patients with dapagliflozin compared to placebo. Urinary infections were very similar, but when you look at the genital infections, as Dr. Arun also has alluded, tend to have little bit increased fungal infections of the genital system, and the lower limb amputations were also comparable. So, to interpret this particular data, empagliflozin is superior to placebo in improving patients with heart failure, irrespective of the diabetic status. Well, there are a lot of postulations and hypotheses why this molecule is useful in heart failure. It's all difficult to understand. These are all the mechanisms how SGLT2 inhibitors are useful in preventing heart failure. Now, this is very interesting. This in this slide, you could see at the extreme end, it's SGLT2 inhibitors. You could see these are the other medications that the pillars of treatment of heart failure, the ACE/ARB, the ARNI, beta blockers, and MRAs. You could see here from this slide that SGLT2 inhibitors, they're complementary in improving the function of all these particular particular molecules. And we know that in patients with heart failure, you have ACE/ARB neprilysin inhibitors, spironolactone beta blockers, and loop diet. These are the mainstay of treatment. And at this point of time, we know from the DAPA-HF and the Emperor Reduce, we know that SGLT2 inhibitors do have a major role in treatment of our patients with heart failure. That's again guidelines speaking in favor of these particular molecules. So coming back to our patient, the one who has diabetes for a very long time, hypertensive dyslipidemia, he's got old infuval myocardial infarction, he has reduced LV function. So definitely in this subset of patients, SGLT2 inhibitors are going to be beneficial, primarily to reduce the MACE in this subset of patients and to prevent heart failure hospitalizations. So finally, one should keep in mind that presently in somebody with diabetes, multiple risk factors, evidence of cardiovascular disorders, treat them with SGLT2 inhibitors, the MACE could be significantly reduced, the incidence of heart failure could be significantly reduced. And do not consider somebody who's a diabetic, somebody with heart failure, whatever be the armamentarium, whatever be the medications with which he's being treated with, add SGLT2 inhibitor, the outcomes are going to be improved. Thank you so much.
Thank you, Dr.
Okay, Dr. Arun is back.
Yeah. Thank you, Dr. Davidson, Dr. Menon, for your wonderful presentation. There is a question for Dr. Menon. The question is, do you think after this Emperor HF trial, does empagliflozin can be treated as par with metformin if there is an early onset, if we start early or something like that? There's a question from the audience actually.
Yeah, I think it would be more for that question would be more for Deepak, but I'll answer that first and then let Deepak take it because it's more a cardiac kind of perspective there. But yeah, I think so. Yes. So if somebody has, the question is, if the patient, somebody has heart failure or reduced ejection fraction to start with, we are talking about using this drug even in non-diabetics, which is what Dr. Deepak was alluding to. So that means in a diabetic, you have to use metformin plus this. I'm not saying you should not use metformin. Certainly, metformin has shown over the years that it has so many other effects in diabetes and its metabolic benefits. So, I mean, anyway, you don't. There is the chance of hypos are not there when you're using a combination. So why not use a combination of this early on? The cardiac benefits is very much there with SGLT2. All the metabolic benefits are very much there with metformin. So both together is the winning choice. That's what you want to use. That's my take on it. And let's see what Deepak has got to say.
Yeah, yeah, definitely. I would agree with you. All the while, so many years down the line, we've been learning that metformin should be the first line of treatment for all our patients with diabetes. So we, even in cardiology, we tend to treat everyone with metformin. As well, at this point of time, we know that somebody with the reduced ejection fraction, he's going to be hugely benefited with SGLT2 inhibitors. That's a scenario wherein we would definitely advise our patients to be on SGLT2 inhibitors, leave alone the cost part of it. We would definitely advise them to be on these particular molecules so that the outcomes are significantly improved, especially the MACE as well as long-term hospitalizations could be significantly reduced.
Yeah, thank you, both of you. And sir, Dr. Deepak, there is a question from audience. Can empagliflozin can be used in a patient with a multiple CV risk factor? If yes, then if you compared empagliflozin with dapagliflozin, which is better in your clinical experience?
Yeah, this particular question, we hear on and off during all the webinars, which molecule is better. But at this point of time, let's say a couple of years prior, maybe in 2018 or 2019, nobody would have asked this particular question because we know that the data is totally in favor of empagliflozin. We had the Emperor outcomes trial that was published in 2015. And since then, we've been using this particular molecule primarily to reduce the MACE in future as well as heart failure risk. Now, at this point of time, we have two trials. One, the DAPA-HF trial published almost a year ago, and secondly, the Emperor Reduced trial that's been published with empagliflozin. So at this point of time, we know that when you want to primarily looking at the data, when you want to treat a patient with diabetes, no heart failure, no cardiovascular events documented, you would definitely try to starting on empagliflozin at that point of time, looking at the MACE in future as well as hospitalizations to reduce hospitalizations. hospitalizations. But then we know that we've been using this particular molecule to treat heart failure. The Empagliflozin has been used for the last 1 year by many of us in primarily to treat heart failure alone. Probably we are continuing to use that, but at this point of time, the data says that both these molecules are almost similar when it comes to heart failure. The outcomes are almost similar. So probably 1-to-1, probably you need to probably 50-50 would be the chance for these two molecules in treating patients with heart failure. One cannot say that one molecule scores over the other in treating heart failure. Basically, everyone debates that you have the cardiac outcomes, that is cardiac mortalities reduced in the DAPA-HF trial, which is not typically seen in the Emperor reduced trial. But then the difference is the design of the trial. It's not that the molecules are hugely different. It's primarily the design of trial made out such sort of differences.
Okay, thank you, Dr. Deepak, Dr. Arun. There is no more questions, so we're concluding the session. So thank you, Dr. Deepak, Dr. Arun, for your wonderful presentation, sharing your experience. And on behalf of Lupin, we thank you and we'll see you in the future meetings.
Thank
care.
you very
so
much.
much. Thank you so
Thank
much.
you very much. Thank you.